So imagine you're looking at an MRI of an older patient's brain, right?
Right, just a standard scan.
Yeah, standard scan. You're looking at the image, and instead of seeing a massive, obvious stroke, you see this scattered constellation of tiny dark dots.
Yeah, it's really distinctive.
It looks exactly like a dusting of black pepper, and it's concentrated almost exclusively right along the outer surface of the brain. Just, dozens of these little black flecks sitting there on the cortex.
It's a really profound visual, honestly.
It really is. And that dusting of pepper, well, that's the visual fingerprint of a mystery that we're going to solve for you today.
Exactly. And it represents a condition known as cerebral amyloid angiopathy, or CAA.
CA, right?
Yeah. And while that might sound like, a highly specialized term meant only for a neurology ward, understanding what creates that dusting of pepper, well, it fundamentally changes how we view brain health.
Oh, absolutely. Strokes, cognitive decline in older adults, all of it.
Right. It's this hidden mechanism behind brain aging that is quite literally just hiding in plain sight.
So our mission for this deep dive is to demystify this entirely. We want you walking away with a deep medical-grade understanding of this condition.
But without, hitting a wall of dense medical jargon.
Exactly. Because if you have older parents, or, frankly, if you plan on getting older yourself, this is happening in the background of human aging.
It's very common, yeah.
So let's just get right to that dusting of pepper. If we zoom in on one of those little black flecks on the MRI, what are we actually looking at?
Well, to understand the macro-level strokes that actually put people in the hospital, we have to look at the mechanics of the blood vessels themselves.
Okay.
Mechanistically, CAA is the selective buildup of a very specific protein. It's called beta amyloid.
Beta amyloid.
Right. And it deposits directly into the walls of the cerebral blood vessels.
Okay, let me pause you there. Because, when people hear protein buildup in a blood vessel, they usually picture a blockage, right?
Sure, like a plaque.
Yeah, exactly. Like a clump of cholesterol just clogging the tube so blood can't get through. Is that what's happening here?
Oh, that's a crucial distinction to make. No, it is not clogging the inside of the tube at all.
Oh, it's not?
Not at all. The beta amyloid is infiltrating the actual physical wall of the artery.
The wall itself?
Right, because blood vessels aren't just, dead plastic pipes. They are living tissue with muscle layers that expand and contract.
Right, they have to pulse.
Exactly. So this protein weaves itself into the living tissue of the wall itself. And the demographics of who this happens to are pretty striking.
How so?
Well, it is genuinely rare to see this before the age of 55. But as we get older, the frequency of this protein infiltrating the blood vessels just skyrockets.
Wow.
Yeah, by the time you look at unselected autopsies of people over the age of 90, roughly 60% of them have this condition.
Wait, 60%?
Yep, 60%.
So if you make it to 90, you are literally more likely to have this beta amyloid in your brain's blood vessels than not?
Exactly. The aging process is just deeply intertwined with this protein deposition.
Okay,
But what's interesting is it doesn't just attack the entire brain indiscriminately.
where does it go?
It primarily targets the small and medium-sized arteries of the cortex and leptomeninges.
All right, let's translate that a little bit for everyone. The cortex and leptomeninges, we're basically talking about the outermost layers, right?
Correct. The superficial vessels.
The surface tissue and the superficial wrapping of the brain.
Exactly.
Which, that brings up an analogy that I think really helps visualize what's happening here.
I love a good analogy.
Right. So think about the plumbing in a very old house. Over decades, you get this mineral scale, this hard rust and calcium buildup that infiltrates the pipes.
Yep, exactly.
And it replaces the flexible metal with something really stiff and brittle. That is essentially what this beta amyloid protein is doing. It's biological rust in the plumbing of the aging brain.
That's a great way to picture it, yeah.
But here's the bizarre part. This rust only seems to accumulate in the outer superficial pipes. Why just there?
Well, what's fascinating here is that this specific location completely changes the clinical picture, and it helps us differentiate it from other common problems.
Like what?
Let's contrast this CAA rust with the kind of brain damage caused by, say, classic high blood pressure, hypertension.
Okay, a very common issue.
Right. Over a lifetime, high blood pressure severely damages the deep structures of the brain areas, like the basal ganglia.
The deep central core.
Exactly. If we use your house analogy, hypertension floods the basement.
Ah, okay, the basement of the brain.
Exactly. Hypertensive bleeds happen down in the basement. But CAA is entirely different.
Because it's on the surface.
Right. Because the affected vessels sit superficially, right on the surface, any bleeding from them naturally lands in the peripheral outer lobes of the brain.
I see where this is going.
Yeah, to keep the analogy going, CAA strikes a penthouse.
The basement versus the penthouse. I love that. That perfectly explains why medical professionals focus so heavily on what they call lobar hemorrhages.
Precisely.
A lobar hemorrhage is just a bleed in the outer lobes of the brain, the penthouse, because that's the only place these specific rusty pipes even exist.
That's it, exactly.
But this brings up a mechanical question for me. Okay, so the pipes are rusty. They have this beta amyloid infiltrating the walls.
Right.
But rust alone doesn't necessarily make a pipe spontaneously explode on a random Tuesday, you know?
Okay.
What actually pushes these vessels to the breaking point?
To answer that, we really have to look closely at the microscopic anatomy of a failing vessel wall.
Okay.
When pathologists look at these vessels under a microscope, they see how the beta amyloid protein essentially suffocates the living tissue of the blood vessel.
Suffocates it. Wow.
Yeah. The healthy muscle and structural cells in the middle and outer layers of the artery wall simply die off, and they're replaced by this stiff, dead protein.
So the wall completely loses its elasticity. I mean, it can't stretch and bounce back with every heartbeat anymore.
Precisely. And that causes a severe weakening of the wall.
Yeah.
Because remember, blood is still pulsing through at high pressure.
Right. It's still a functioning artery.
Right. And this weakness leads to the formation of microaneurysms.
Mm-hmm.
These are tiny, balloon-like, bulging weak spots, right where the amyloid has destroyed the tissue.
That sounds incredibly fragile.
It is. In really advanced cases, the tissue death is so severe that the vessel wall literally splits into concentric layers.
Wait, really?
Yeah, under a microscope, it creates this distinct double-barrel appearance.
A double barrel? You mean like the single tube of the artery delaminates and splits into two fragile layers?
Yes, exactly. You have a rotting, rigid pipe that is structurally tearing itself apart from the inside out.
Wow. So you have these incredibly fragile double-barreled penthouse pipes just waiting to go. I'm assuming it doesn't take much to trigger a rupture at that point.
It really doesn't. Sometimes just a sudden spike in blood pressure is the final straw.
Just a normal blood pressure spike.
Yeah, or head trauma. That's a very common trigger, even just a minor fall. Neurosurgical procedures can disrupt them too.
That makes sense.
But medications also play a massive role, particularly blood thinners like warfarin.
Oh, man. Which is a terrifying catch-22 for an elderly patient.
It really is.
I mean, they might be put on blood thinners to prevent a heart attack or a standard blood clot stroke, but because their superficial brain vessels are basically made of brittle rust.
That medication can turn a microscopic leak into a catastrophic penthouse bleed.
Right. That is the exact clinical dilemma doctors are facing every day with older patients.
Absolutely.
But before a major catastrophic rupture happens, the sources point out that these patients often experience something highly unusual. It's like a massive warning sign.
Right. They're called amyloid spells.
The amyloid spells, these are absolutely fascinating.
They really are.
The way they present clinically, I mean, they are described as transient focal neurological episodes. They're rarely disabling in the long term, but they are incredibly distressing for the patient and their family.
Extremely distressing, yes.
Like a person might suddenly lose the ability to speak or experience spreading numbness or weakness on one side of their body. And then after a few minutes or hours, it just goes away. Normal function returns.
Right. And at first glance, a triage nurse or an ER doctor might reasonably think, oh, this patient just had a mini stroke, a TIA.
Right, that's what it looks like.
Or perhaps they just had a focal seizure. But in the context of CAA, it is almost always something else entirely.
Wait, if it's not a mini stroke and it's not a seizure, what is actually causing the speech center or the arm to just turn off and then turn back on?
Well, when doctors run an EEG to monitor the brain's electrical signals during one of these spells, they usually don't see the chaotic electrical storms that define epilepsy.
Okay.
Instead, the mechanism is believed to be something called cortical spreading depression.
Okay, I am definitely going to need you to unpack cortical spreading depression. What does that actually look like in the brain?
Think of it like a rolling blackout moving slowly across a city's power grid.
A rolling blackout?
Yes. It is a literal wave of electrical silence that creeps millimeter by millimeter across the highly sensitive surface of the cortex.
Wow.
As this wave of suppression rolls over a specific area, it temporarily shuts down whatever brain functions are housed there.
So if the rolling blackout creeps over your motor strip, your arm goes limp.
Exactly. And as it moves past the motor strip and over the speech center, your arm might recover, but suddenly you can't talk.
That is wild. You can literally trace the physical movement of the electrical blackout just by watching the patient's symptoms shift.
You really can.
But what causes the power grid to trip in the first place? Like, why does the blackout even start?
The trigger is usually microscopic bleeding. Remember those fragile double-barreled pipes sitting right on the surface?
Right. The rusty pipes.
Well, sometimes they don't catastrophically burst, they just weep. Yeah, they leak a microscopic amount of blood onto the highly sensitive surface tissue of the brain. It might just be a tiny speck of blood, but blood is incredibly irritating to brain tissue outside of a vessel.
Ah, how good.
That tiny irritation is the spark that trips the breaker and kicks off the rolling wave of electrical shutdown.
So a tiny leak causes an electrical short circuit, which causes a temporary rolling blackout. That makes perfect sense.
Right.
But if that's the mechanism, how do you stop it? Because there is a temporary fix for these spells, isn't there?
There is, and it's quite elegant, actually. If a patient is having recurrent amyloid spells, doctors can put them on a short 1 to 3 month trial of specific anti-epileptic medications.
Okay.
Drugs like topiramate, valproic acid, or gabapentin.
Wait, let me push back on that for a second. You just told me these spells are not seizures.
Right, they aren't.
If there's no electrical storm, why are we giving them seizure medication?
It's a great question. We aren't using these drugs to stop a seizure. We are exploiting a side effect of how they work.
A side effect.
Yeah, these specific medications are highly effective at preventing that cortical spreading depression.
Oh, I see.
They essentially stabilize the city's power grid, making it much harder for that tiny speck of blood to trip the breaker.
Oh, that's clever.
It gives the brain time to reabsorb and clean up that irritating microscopic leak. Once the blood is cleared and the symptoms are controlled, the medication can often just be tapered off.
That is a brilliant use of pharmacology. But, understanding how to stop a spell brings us to a massive logistical wall.
It does.
Yeah. I mean, we know the beta amyloid protein is there. We know it's rusting the superficial pipes, causing micro leaks and triggering rolling blackouts.
Right.
But doctors cannot practically or safely drill into the skull of an 85-year-old patient to perform a brain biopsy just to prove this microscopic rust exists.
Definitely not.
So, in a living, breathing patient, how does a doctor actually confirm this diagnosis?
Well, because a physical biopsy of the brain tissue is usually totally out of the question, the medical community relies on a highly validated logic puzzle. It's called the Modified Boston Criteria.
Okay, the modified Boston criteria.
Right. It's a diagnostic tool that allows doctors to confidently diagnose CAA just by looking at patterns on brain scans and piecing together the patient's medical history.
Okay, let's walk through this logic puzzle together. Because if you have an older family member who goes to a neurologist after a brain bleed, this is exactly the math the doctor is doing in their head.
Absolutely.
What's the first rule of the Boston criteria?
The very first requirement is age. To diagnose probable CAA without a biopsy, the patient must be 55 years or older.
Because, as we established earlier, this specific biological rust almost never accumulates before that age.
Exactly.
If a 40-year-old comes in with a bleed, it's almost certainly caused by something else.
Right. Age is the baseline. Once they meet the age criteria, the doctor looks closely at the MRI.
Looking for the penthouse bleeds.
You got it. Specifically, they're looking for multiple hemorrhages that are strictly restricted to those outer penthouse regions we talked about, the lobar, cortical, or cortico-subcortical areas.
And if there are multiple bleeds and they are all strictly on the outer edges.
That heavily implies the superficial pipes are the culprit.
But what if they haven't had multiple massive bleeds? What if it's just one?
The criteria account for that, too.
Yeah.
A patient can still be diagnosed with probable CAA if they have just one lobar hemorrhage, as long as it is combined with evidence of that microscopic weeping we talked about earlier.
The tiny leaks.
Right, which doctors call superficial siderosis. If the MRI shows a single penthouse bleed, plus tiny streaks of old blood irritating the surface of the brain, the diagnosis holds.
Okay.
Crucially, the final step of the puzzle is ruling everything else out. There cannot be any other identifiable cause for the bleeding. No massive head trauma, no brain tumors, no vascular malformations.
So age 55 plus, bleeding strictly in the penthouse, and no other obvious culprit. And if a patient has only a single hemorrhage, or just those tiny microscopic streaks of old blood with no major bleed, they fall into the possible CAA category.
Correct.
And this is exactly where we bring back the hook from the very beginning of our deep dive, that visual of the dusting of pepper.
Right, we've come full circle.
Because doctors use a very specific MRI sequence that is exquisitely sensitive to detecting iron from old blood, Those tiny dark dots aren't active gushing strokes.
No, they're not.
They are the literal scars of old, tiny microleaks.
And finding that visual fingerprint, that dusting of pepper isolated strictly to the outer lobes, is vital because it completely changes the patient's future.
The stakes here are huge.
Massive. Differentiating this from a deep basement bleed changes everything.
But why? I mean, a bleed is a bleed, right?
Not when it comes to recurrence. If a patient comes into the ER with a brain bleed caused by deep hypertensive disease, the flooded basement, their risk of having another spontaneous bleed in the next year is relatively low. It's around 2%.
Okay, 2%. You can manage that. You lower their blood pressure and just monitor them.
Right. But if the doctor spots that dusting of pepper and diagnoses probable CAA, that patient's recurrence risk jumps to a meaningfully higher 5 to 10% annually.
Wow. 5 to 10%.
Yeah, that structural fragility in the penthouse is a constant looming threat. And because the vessels are right on the surface, these patients are also incredibly prone to overlying subdural hematomas.
Which is blood pooling just outside the brain beneath the skull.
Exactly. And that shows up in roughly 20 to 30% of these cases. Knowing that risk fundamentally changes how aggressive you can be with other treatments, especially blood thinners for heart conditions.
Which paints a rather grim picture, honestly.
It can seem that way, yes.
Up until this exact moment, everything we've discussed makes CAA sound like a one-way street. It sounds like an inevitable, structural, and entirely unfixable problem of aging. You get older, the biological rust builds up, the fragile pipes eventually split, and there is absolutely nothing modern medicine can do about it except try to manage the collateral damage.
That's a very common view, yeah.
And honestly, it's easy to see why doctors fall into that exact mindset. A doctor sees a patient with a known history of this dusting of pepper on their MRI. That patient suddenly develops a severe new headache, a seizure, or a rapid cognitive decline.
And the doctor naturally assumes.
Well, the rusty pipes are just getting worse. It's just more unfixable bleeding.
Yeah.
But if they make that assumption, they might miss a massive life-saving plot twist.
Yes. It is arguably the most important plot twist in the management of this condition. Because while the slow structural rusting is unfixable, there is an exception to the rule of permanent decline.
Right.
It is a condition called CAA-related inflammation.
Okay, break this down for us. Because the idea that a sudden, terrifying decline in these patients might actually be fixable is mind-blowing. What is the inflammation actually doing?
You have to picture what happens when the immune system suddenly goes rogue. Usually the brain is protected by the blood-brain barrier. The immune system just ignores it.
Right.
But in a specific subset of patients, and notably we look for this in patients slightly younger, typically 40 and older, the immune system suddenly wakes up. And it recognizes this beta-amyloid protein not as a normal part of aging, but as a dangerous foreign invader.
So it's essentially a sudden, violent allergic reaction to the brain's own biological rust.
That is an excellent way to conceptualize it.
Right.
The immune system mounts a furious inflammatory attack against the brain's own blood vessels, trying to clear out the amyloid.
And the clinical presentation of this attack is dramatic, right?
It's terrifying. Patients present with rapid onset, severe headaches. They might have actual seizures. Their cognitive function plummets rapidly. They experience severe behavioral changes, and they develop those focal deficits, like losing the ability to move a limb.
So to a family member, and even to a doctor who isn't looking closely, this looks like the end.
It really does.
It looks like the patient is having massive strokes or plunging into sudden severe dementia. But if a doctor knows about this inflammatory plot twist, what do they see when they look at the MRI?
Well, alongside the typical superficial bleeding, the MRI will show something totally different.
What is it?
Widespread, asymmetric swelling in the brain's white matter. The inflammation causes severe swelling that extends deep into the wiring just beneath the cortex.
Wow.
Yeah, it looks like massive catastrophic brain damage. But here's the revelation. Unlike a structurally ruptured pipe, this massive inflammatory crisis is completely and substantially reversible.
Reversible. That's incredible. And the treatment is surprisingly straightforward. You just use steroids.
High-dose steroids, yes. The standard protocol is a heavy course of intravenous methylprednisolone for 3 to 5 days.
Okay.
And that's followed by a rapid oral taper of prednisone.
So you're basically carpet bombing the immune system, forcing it to immediately stand down and stop attacking the blood vessels.
Precisely.
And when you suppress the immune system, the swelling goes away. The clinical symptoms can completely resolve.
The radiographic swelling disappears and the patient's rapid cognitive decline halts. and often reverses.
That's just amazing.
It really is. It is one of the rare, profound situations in neurology where a condition causing severe brain swelling, hemorrhages, and devastating cognitive symptoms can be reversed with standard medical therapy.
Does it come back?
Now, it is usually monophasic, meaning it's a one-time crisis that doesn't return once treated, though, we do see the inflammation relapse in up to a third of patients.
Still, the vital takeaway here, especially for anyone advocating for an aging family member, is that a sudden, rapid decline in a patient with CAA isn't always the inevitable end of the road.
Right. It might be an inflammatory fire that you can actually put out.
That is an incredible paradigm shift. So let's synthesize the journey we've just taken together today.
Let's do it.
We started by looking at how a specific protein beta amyloid acts like biological rust, selectively targeting and destroying the superficial penthouse blood vessels of the aging brain.
Right.
We uncovered why its distinct dusting of pepper visual on an MRI separates it from typical high blood pressure damage.
The basement versus the penthouse.
Exactly. We explored the mechanics of how these rusted pipes weaken, split into double barrels, and trigger the rolling blackouts of amyloid spells.
Yep.
And finally, we uncovered the vital importance of looking closely at a patient's rapid decline, because what looks like structural decay might actually be a highly treatable immune system overreaction.
And as we step back to look at the larger implications of this disease, there is one final profound connection from the source material that I want you to consider.
Oh, what's that?
We know that between 10 to 30% of patients with CAA go on to develop progressive clinical dementia.
Okay, that's a significant amount.
Furthermore, when pathologists examine the brains of CAA patients after they pass away, they find something called neuritic plaques in roughly half of all cases.
Wait, neuritic plaques, those are the defining physical hallmark of Alzheimer's disease.
Exactly. The very same plaques that define Alzheimer's are found in half of these patients, which establishes a very real, undeniable physical link between the two conditions.
Oh, wow.
And it raises an extraordinary philosophical and medical question for you to mull over. The protein that causes CAA is beta amyloid. The protein that clumps together to form the plaques of Alzheimer's disease is the exact same beta amyloid.
So if this exact same microscopic protein is responsible for both the explosive structural vessel ruptures of CAA and the slow, insidious cognitive decline of Alzheimer's disease,
Right.
are these two seemingly distinct diseases actually just two different ways? The exact same microscopic rust destroys the human brain.
It forces us to ask, is the root cause simply the aging brain losing its ability to clear away its own biological waste?
That's a huge question.
It is. And if amyloid in the tissue causes dementia, while amyloid in the vessels causes strokes, what does that mean for how we must think about protecting our minds as we age?
That is a lingering thought if I've ever heard one. From a dusting of pepper on an MRI to questioning the very nature of how our brains age, decay, and lose their memories. We want to enthusiastically thank you for joining us on this deep dive. Keep asking questions, keep looking past the obvious, and we'll see you next time.